Welcome to Today in BC. I'm Peter McCully. Reimagining healthcare in British Columbia was the theme of one of the plenary sessions held at the recent Union of British Columbia Municipalities meeting. BC communities and residents are experiencing unprecedented challenges with the healthcare system, which includes the closure of emergency rooms, long wait times for surgery, difficulties in finding a family physician, problems with recruitment and retention of healthcare professionals, and inconsistent access to ambulance service. This podcast will be longer than the norm. Although some of the sessions was edited for time and content, we thought the topic and discussion was timely given the state of healthcare in BC and wanted to offer you the opportunity to hear the presentations. Attended by mayors and councillors from across the province, the session explored how those issues are affecting communities in all areas of the province, both urban and rural. And members of the panel discussed ideas for transforming the healthcare system in BC. Gabby Wickstrom, Mayor, Town of Port McNeill, Merlin Blackwell, the Mayor of District of Clearwater, and Pete Fry, a councillor from the City of Vancouver, talked about the impact of disruptions to the healthcare system and how they were affecting their residents. Troy Clifford, the President of the Ambulance Paramedics and Emergency Dispatchers, George Abbott, President of Circle Square Solutions and a former Minister of Health, as well as Dr. Carrie Jang, Faculty of Medicine of UBC, and Dr. Ray Markham, a rural family physician, offered transformative solutions to the problems that were being discussed. We'll listen in when Today in BC continues.
From the latest community news to informative, entertaining reads for travelers and the cannabis curious, just visit your local Black Press Media community newspaper website to sign up today.
Today in BC is a Black Press Media podcast. I'm Peter McCully. The Reimagining Healthcare in British Columbia session was hosted by Lori-Ann Rutenberg, a councillor with the City of Cornell and UBCM president. The session began with an address by the Honourable Adrian Dix, Minister of Health.
Welcome to this session, Re-envisioning Healthcare in BC. My name is Lori-Ann Rutenberg, councillor with the City of Cornell, and I am the UBCM president. I am pleased to be serving as chair for this clinic. We will begin the plenary with the Honourable Adrian Dix, Minister of Health, who will speak to the provincial government's primary care strategy. Dix is the MLA for Vancouver Kingsway and was first elected in 2005. He was the leader of the official opposition from 2011 and 2014. Prior to becoming an MLA, Minister Dix was the Executive Director for the Canadian Parents for French, BC Yukon branch, a nonprofit organization promoting language education. Please welcome Minister Dix.
Thank you very much, and I am really honored to be here today on the territory of the Squamish First Nations, and honored to be here with you. And I think one of the things I'd just like to start by expressing, because I heard the term healthcare crisis, and just so that we understand, we've been in a healthcare crisis since at least March of 2020, when a pandemic was declared in our world. And before that, dating back to 2016, with respect to the overdose public health emergency that has consumed many of you and many of your communities. This is a major challenge of our time. But I wanted to start by expressing a real sense of gratitude to all of the people in this room for all that you've done, in particular, over the last 2.5 years. This period of pandemic in our province has been profound. It's been profound for the healthcare system and for communities. And unlike other places in the world, I think, we've had a degree of engagement from everybody, but in particular, I would cite municipal governments who have been remarkably supportive. In March 2020, just to put this in context, because it directly relates to the challenges we face today, and we'll go back a little bit and forward a little bit to what we're facing today. Within 2 weeks, we essentially deferred 30,000 surgeries in our province. We completely transformed the primary care system. In the year prior to March 2020, we had 98% of primary care visits were in person. In the immediate year after, that number was 30%, most radical change we'd ever seen to a primary care system we'd ever seen. And we instituted public health measures everywhere in the province that were transformative to our lives. In fact, everybody's life was affected, and you don't often hear that with single sets of government decisions. And we got through it, and it didn't stop there. Many of you especially from northern BC and the Northern Health Authority, will remember the fall of 2021, really from August in the Interior Health Authority in 2021 through to the fall, when hundreds of people were transferred. Hundreds of people were transferred. Thank you, Troy, and all the paramedics, but all the others. Because when you have a transfer from Chetwynd or Mackenzie or Dawson Creek or Terrace, it involves everybody from healthcare workers to nurses to doctors to ambulance paramedics to everyone on the ground. Hundreds of people went from critical care in the north to critical care beds, largely in Metro Vancouver and Southern Vancouver Island. Hundreds of people are walking around the streets of those communities because we did that, because we made the changes to do that, because we made the additions to air ambulance to do that, and the changes, and it took whole communities of healthcare workers to do it together. So I wanted to start by that sense of gratitude, because we have never, ever, and George and I are students of the healthcare system and have served in this job as well, ever asked so much of our healthcare system, ever come close to asking so much of our healthcare system as we have in the last 2.5 years. And together, we delivered, I think, the best response to COVID-19 in the world. Not because of me, or the government, but because of us. Because in a time when we were asking people to do things they had never done before, ever done before, they stepped up and did it in their communities. And it was difficult, and it was hard. What? The pandemic's still on, and it's still difficult, and it's still hard. The last week we have records, 15,700 healthcare workers were sick in the public healthcare system. Typically pre-pandemic, that number is 8,000. Very hard, of course, to plan for that. And we're going to be hearing some of the challenges, especially in smaller communities, in dealing with that soon in this discussion. But it continues to exist this fall, and we're just starting. I don't know if anyone here, probably if you're clinically vulnerable, you may have received an invitation. We're going to ask everyone to get vaccinated again, and that isn't someone else doing it. That's doctors and nurses and healthcare workers and everyone else involved in that process. We've had, because of our response to COVID-19, 2 very good flu seasons, but we can't guarantee that this year. In fact, our expectation is more flu this year than last year, more flu this year than the year before. The pandemic is still on, and we are still responding to it. We're responding differently because the vast majority of us, 94% of us, got vaccinated, an action of primary care in our communities. And 92% of us got it a second time, and we are hoping for similar numbers in this fall, and we need similar numbers this fall to keep people protected. But because people are vaccinated, the impact of COVID-19 is different and less than it's been before, but it is still profound, and it affects our healthcare system at every level, every day. We talked about primary care, 98% of appointments in person. The last 3 months, that number has been about 56%, just to put that in context. And while I believe in the value of virtual care, and it will play an important role in our future, and I know that primary care cannot strictly be done over the phone. And we need to work that through with our community of doctors. So what I'm saying, I think, is that we have gone through this period where our public health care system has delivered in a way that it has never delivered before. Since I've been Minister of Health, we've added 38,000 people to the healthcare system. Can you imagine how many people that is? That's basically, in the current configuration, fills BC Place Stadium. That's how many people we've added. That's not new people, that's net new people to the healthcare system. 38,000. And you know what everybody in this room is saying to themselves right now? Not enough. Right? That means more doctors, more nurses, more health sciences professionals, especially more healthcare workers, more ambulance paramedics. Still not enough. But I think one conclusion we can draw from this is that our model of healthcare, our public healthcare system, has demonstrated its value. And I am committed, we are committed to it continuing to do that. And so I want to talk to you a little bit about the challenges we face in one part of that healthcare system. We're going to have an opportunity maybe in questions and answers, because I'd love to talk about surgeries and ambulance paramedics and diagnostics. I'd really like to talk about surgeries and diagnostics, because the record is pretty extraordinary in the last 2 years. I want to talk a little bit about primary care and how we deal with that together. Because, and this has particularly been the case, I think, after 2 years of this transformation of primary care into a disproportionately virtual system, we have some real challenges to face that are of long standing. So let's put what those challenges are in context so we understand what they are. First of all, we got too many people who aren't attached to a primary care provider, either a doctor or nurse practitioner, broadly speaking, and that's a significant problem. That number was 340,000 in 2003. It was 908,000. According to the one source of information on this, which is the Canadian Community Health Survey. When I became Minister of Health, it went down a little bit. In the first couple of years I was Minister of Health in the period of the government as we pursued initiatives, but people kept coming to BC and our population kept aging in that period. And now, clearly, the next time those numbers come out, it's going to be higher. But to say that this started in April or March, this issue of attachment has been with us for some time. And it's critical for people. Because two things are happening. One, the population is growing. We're the place of fastest growth, and that means in communities. Two, the population is aging, meaning the centrality of primary care is greater than it's ever been before. It's different if you're a 30-year-old construction worker in good health coming to BC. Your needs for primary care are different than if you're moving as a 75-year-old senior to BC, where you've had a primary care provider your whole life and you really need one now. So the demand is significantly higher. That aging population is also affecting our population of health professionals. And our system isn't suited to these two phenomena: more people, more demand, more acuity, right? And acuity is important. We'll come back to this in a moment. If you're a doctor and your patients are more seriously ill, you can see fewer patients in an hour, and that affects your ability in a fee-for-service system to function, to run your business. It also affects the quality of care. And so we have to adapt to that, and we have to see changes to that. So we've got more unattached people, we've got increasing complexity, and we've gone through 2 years where people, to a degree, have moved away from the kind of primary care they've received in their lives directly, but also in their own lives. They may have put off some of the things that they now need to deal with, and indeed, it being 2 years later and then being 2 years older, they need to deal with now. So what do? Some of it is what we have been doing. And I'll just talk about this briefly because I want to focus on what we need to do next, because I think that's what people want to hear about. We need to transform our system of healthcare. And that means doing what I think health ministers have believed is necessary for a long time, which is moving our system towards team-based care, allowing all of our health professionals, be they doctors or nurse practitioners or pharmacists, to work to the full extent of their skills, or nurses or anyone else, work to the full extent of their skills. And that means building out primary care networks where we build out team-based care in cooperation and consultation, in particular with local divisions of family practice. There are 59 of them in BC. There are about 1,200 new hires in primary care in these areas. And where are those new hires most felt? In mental health and addictions. Because that is what, especially local divisions of family doctors, who are basically local doctors, have said they need it. Imagine being a doctor and someone presents, as we increasingly say, with a chronic mental health condition. Often in their challenge is, what do you do at that point? Who do you refer them to, right? It's different when it's an acute care circumstance, you know them, but where do you refer them? Having places to go in a primary care network where health professionals are working together provides better care, and it allows doctors to do what they do best and most importantly, which is not, with great respect, be social workers, right? We need to be social workers, people who are trained to be social workers, and that's also what we've added to primary care networks. So we need team-based care, and that's what we've been building out. And so some of that is urgent and primary care centers, and you've heard of them, but we have 2,000 clinics, 27 urgent and primary care centers, about 350 people working in those urgent and primary care centers, about 1,100 to 1,200 people now hired new incremental and primary care networks to build out team-based care. And that is not the only solution, but it's one, allowing people to work to the full extent of their skills. Secondly, we need more people. We need more people, and I've got a guy over there, his name's Alex McDonald. He's my ministerial assistant. He's going to put the finger, because I don't have a text with me, when I pass my time, and then I'm going to generously sit down and let the next speaker speak, just so we understand. This could go on a while if I get going on healthcare, as you expect, but we need more people. So since, in terms of doctors, we've added 60 residency positions, we need to add more. In nurses, when I became Minister of Health, we were 10th. It would be great if there were 100 provinces, but there are only 10. 10th in Canada in registered nurses, 10th in Canada in nurse practitioners. Our ambulance system was 30% permanent employees in the 21st century. And we have to change some of those things. We have to, some of those things, and you are seeing that. Because the key question in health human resources is ensuring that we not just have the health human resources for now, but we have it in 5 and 10 and 15 years. And that means training more people and training more people in the community, whether it's the new spaces in Fort St. John, the new spaces in Prince George, the new spaces around the province that we've put in place. We need to train more people. So earlier this year, we added, in addition to what we've added before, because we've led Canada in new registered nurses since 2018, that we've added 603 new nursing positions and 330 new allied health positions. And as I say, 60 residency positions. And we need to continue to add more and to encourage people to take part and to see their future in healthcare. And I need to add, obviously, the work we're doing with healthcare workers in long-term care and the additions we've made there. That's the first set of things. More spaces, more position, and more encouragement. And then supporting people in the early part of their careers to stay in the system where we need them to be in the system, which is critically important. So that's a second thing. We need more people. Third, we need more barriers to care. Now, you're a doctor who's the best primary care doctor in Dublin. And George and I decided we were going to go to Dublin, which would be a good idea. I think we'd enjoy it, and recruit this doctor. If he came here, he'd have to work 2 years under supervision. 20-year veteran, primary care in Ireland, in Dublin, in a community with a high quality of health care. That's what's required. We've got to break down some of those barriers to people with international credentials coming. In April, we did that with nurses, and we need to expand the programs we have in place for internationally educated doctors to bring more to communities. But we have to do that. We have to make our system not more rigorous, not by making it harder to become a doctor here, but to support doctors when they come here and want to work here. And that is a critical aspect to what we need to do. Third, we got to change the way we pay people. The fee-for-service model, the president of the Doctors of BC said it recently, the model by which we pay doctors is broken. Well, British Columbia has more fee-for-service than any other province. And you can talk about the history of that, how the fee-for-service system was put in place in part by doctors. But that system for young doctors isn't working very well. So we've got to provide more and better alternative options for doctors to work. Finally, it seems to me, in addition to all of those things, we've got to allow other professions to work to the full extent of their skills, and that includes people such as pharmacists. There are thousands of them. They're in your community, and their skills and their training is underutilized in our healthcare system. We've got to do all of these things. And I believe together we can do them, and more things than that in terms of using our healthcare system to meet the challenges of today, just as we have in the last little while. I just want to tell you a brief story to say that I believe we can do it. In March of 2020, I made, I think, the hardest decision I've ever been involved in. Much of what I do, and George will remember this from when I was health critic for the official opposition, I really have focused in my political career on wait times for surgery and wait times for diagnostic care. This has been a vital important because I know and you know that when people wait, they get sicker and their recovery is worse and they're waiting in pain, and you need to deal with those sorts of things. In March of 2020, as I said at the beginning of the speech, we canceled essentially or delayed about 30,000 surgeries in our province. Non-urgent scheduled surgeries, all of them, though, medically necessary, and all of them essential to people whose lives were changed and transformed and were waiting and were expecting it in that moment. Sometimes they had surgeries scheduled a week later, and they were delayed, and many people thought they were canceled. And we made a commitment then that we weren't going to forget those people or any of the people afterwards. And so we put in something called surgical renewal. And there were 84 so far separate initiatives, 84. Extending hours, increasing training, 300 new trained surgical nurses. And this past year, in a pandemic, when we also had to defer surgeries during the Omicron variant of concern, we did dramatically more surgeries than ever before. And we reduced wait times for surgeries in a pandemic, equally on diagnostic care. Okay, Minister of Health, we did 174,000 MRI exams last year. We did 297,000. And that involves, and just to be clear where those took place, 20 per 1,000 in 2017 in the Northern Health Authority, meaning they had 1/3 the service of an average person in Ontario. And that was changed, and changed largely in a pandemic. In the pandemic, we've added net 70,000 that total. We did it in the other 70 in the 2 years before the pandemic. These are enormous achievements. You do it through training, through multiple measures, by engaging with people, by engaging with unions, by engaging in communities, and by expanding your capacity to meet what is expanding demand in our society. These are things that we can do together. And on primary care and on other challenges facing healthcare, we can also do them together. I want to be able to say, and we need to be able to say, that we are committed to our public healthcare system. I know I am, I know our government is, I know the people of BC are, and people of BC have seen its value. But we need to be committed now to that positive message. I've always believed that we have the best public education system in the world, even when George was minister. And sometimes I think those of us so wanting it to be better focus on that and don't focus on its value. Our public healthcare system has demonstrated its value, and we need to send a message to a new generation of healthcare workers that we are going to be there for them and there for the system, that we have responded to the most extraordinary challenges that anyone has ever faced in a healthcare system here and around the world, and we've done so in a way that we can all be proud of, every one of us in the province. And we can keep doing it. We will keep doing it. We need to keep doing it. There is a challenge in healthcare. If you're living in Clearwater, or you're living in Chetwynd, or you're living on the downtown east side, or you're living anywhere in BC, you know that. But we are capable of responding to these challenges together. Thank you, and I look forward to hearing all the presentations.
So thank you, Minister Dix. Next up, we have a community perspective on this issue. We have a community impact trio. Mayor Gabby Wickstrom from the town of Port McNeill, a colleague of mine on our UBCM executive, Mayor Marilyn Blackwell, District of Clearwater, and another UBCM colleague, Councillor Pete Fry from the City of Vancouver. So each of these speakers will spend a few minutes to tell us what is happening in their communities and how it is affecting their community members. Mayor Wickstrom.
Good afternoon, delegates, Minister Dix, and panelists. When I was first asked to present, I thought to myself, sure, we're having problems, but how bad is it compared to others? I'm here to say if you are not yet experiencing healthcare issues, you will be. It is appropriate that I speak before Mayor Blackwell because if we don't move forward on this issue, all of us, we are headed to where Clearwater and others are at. I'm here to share the story of Port McNeill, but in particular the Mount Waddington region, with a population of 11,000 situated in the traditional territory of the Kwakwaka'wakw. The closest major centre to us is Campbell River, a 2-hour drive away with little or no cell coverage. It's important to note because at Christmas we were perilously close to having a total diversion with Alert Bay, Port McNeill and Port Hardy hospitals at staffing shortages. This would have meant a patient needing to be transferred 2 hours plus away, depending on which community. 2 long hours on a road with almost no cell coverage. Hopefully in an ambulance with trained professionals, but perhaps with a scared family member doing their very best to get their loved one to the necessary medical attention. Since March of this year, we started seeing more and more closures and service reductions of our ER. Occasionally, it had to do with lack of physicians, but mostly it was due to lack of nursing staff. Alongside that, our ambulance service is at a critical staffing low. An Ashcroft scenario may not be far off for us. And by the way, training volunteer firefighters to be paramedic level trained is not the answer. Things are at a critical level. It has recently been reported in the media that Alert Bay will be without a family physician by the end of the year, and Port Hardy is in dire need of physicians as well. We have been fortunate enough to recruit 2 new doctors to our community, but I am deeply concerned for the burnout level that will occur when the 4 Port McNeill physicians are left servicing the broader region, which also includes isolated Indigenous communities. Burnout is real. Our nurses are feeling it. With so much funding and focus going to agency nurses, our long-term living in community nurses are feeling used and undervalued. We have made the job of an agency nurse extremely lucrative. We have and still are driving away healthcare professionals with years of experience. Lab technicians, mental health, addictions, physiotherapists, counselors, all these professionals are struggling. Something must change. Because I like to be solutions-based, here are my thoughts on this. We need to have these hard conversations together. That means the province, BC Ambulance, unions, health authorities, Indigenous health, doctors, nurses, municipalities, all of us. Coming together to talk openly about the problems we are facing. What are the HR issues? How can we streamline services to be more efficient? Where are the synergies? Can training occur in our communities? I say yes. COVID has shown us it can. COVID has also shown us that we can work quickly when we need to. Can we work together on daycare and housing as well? Areas healthcare professionals are saying are obstacles for them. We desperately need to talk about the governing bodies of different healthcare professionals. They are the gatekeepers when it comes to certification, and we are experiencing an abundance of obstacles for those seeking to practice from outside the country, even outside of the province. We don't want subpar health care, but why can't we look at things like reciprocal jurisdictions nationally and internationally, where we can agree that training levels are at par with ours? The average age for a family doctor is 52. Are we training enough doctors to fill the current void and the one that is to come when those doctors retire? Why does an RN still need rural training that could take up an extra year? Why can't it be part of their practicum in our communities? The province needs to be asking these questions and working towards a solution. Why a rural coalition? As rural communities, we need to come together to amplify our voices. 2 to 4 nurses may mean a 50% reduction in our workforce and an ER closure. Mayor Laurie Ackerman has said for years that rural BC is the frog in the boiling water when it came to healthcare, but no one listened. I hope the panel today is ready to listen to us and to each other. We are coming with a willingness to offer what we can as municipalities, but we cannot do it without you. If you continue to work in silos, we will never solve this issue. Premier Horgan spoke last week that a team approach is needed. We agree, and it needs to happen across all healthcare disciplines and ministerial boundaries. Thank you.
Thank you, Mayor. Now let's hear what's happening in the District of Clearwater. Welcome, Mayor Black.
Hi, Merlin Blackwell, 4-time cancer survivor, so I come through this with a different perspective than a lot of people, or everybody probably. So Clearwater is on the unceded traditional lands of the Simp people, part of the larger Secwepemc Nation. We are a community of 2,400 people. Service area adds about another 1,500 to 2,000. Right now we have about 1,000 pipeline workers with the Trans Mountain Project in town as well. They rely on a different healthcare system, but also on ours. In summer, for a 5-month period, we average about 75,000 tourists through our town as well. And we are on the busiest arterial highway in BC between the Port of Vancouver and the Alberta oil patch. So there's a lot of heavy equipment comes through there. TI, if you're here, we need to talk about passing lanes because we have almost none of them, which is a great risk to highway rescue and to our ambulance service as well. Since the beginning of this year, we have seen over 60 closures of our ER, whether it be overnight or day and night. They're referred to as diversions by Interior Health. These closures generally last 13 hours, but definitely we've had some 24-hour ones in there as well. We have a beautiful, relatively modern hospital in Dr. Helmeken Memorial with a heroic team of healthcare workers, doctors, nurses, x-ray techs, and they are struggling. Across the street from the hospital, we have an ambulance space with the 24/7 2-car service. We also have a separate clinic where generally we would run on 5 doctors. Right now we have 3.5 doctors, and I have to say 3.5 doctors is a miracle. In this day and age, having 3.5, I'm ecstatic. The fact that other doctors want to come and look at us, it just brings joy to my heart because I know a lot of communities here are suffering way worse than that. Right now we are about 40% short on ED, emergency department, certified nurses to function our ER on a regular basis, ED on a regular basis. If it wasn't for nurses from other Interior Health locations hearing me talk in media and saying, I want to come help, agency nurses as well, we probably wouldn't be open as often as we are. Locums are a struggle. All other nursing and professions are a struggle as well. Our BC ambulance station, as I said, has 2 ambulances. One of those 2 ambulances has maybe done 2 or 3 shifts since the May long weekend. We are down probably 40% on our ambulance crew staff right now. Our ambulance, we all know this from the Thompson-Nicola Regional District and beyond. Your ambulance leaves town, it will stay out of town for a long time. Kamloops has the same crisis we do. Barrier has the same. Ashcroft, Clinton, all of them have the same crisis. We are running on so few ambulances that when one of ours gets dispatched to Royal Inland in Kamloops, the odds of us seeing it back within a couple of hours are just about zip. I have stories from citizens about waiting for hours in pain for our ER to open. They will stay at home and wait out the closure because they know they're going to get seen sooner in Clearwater by waiting on their couch overnight and showing up at 7 a.m. than going to Royal Inland and sitting in a chair overnight. This is where we're at. I have other stories about heart patients in distress and family members who are former medical professionals deciding to transport them to Kamloops because the heart team is not available and they can't wait any longer. Multiple stories on that one. Where we are now. So there is some good news. I think Dix thought we were going to come up here and be incredibly critical. I'm here to tell you our story, but I'm not here to be critical because we are solving things. Right now we are back to 24/7 ED coverage. We have 12 days scheduled so far. I'm knocking on wood that we're going to keep going. Coincidentally, I'm speaking here, just a thought. We have 1 new doctor who's recently come on board. We recruited at least 1 nurse. There's more coming through the system right now as well. Lots of inquiries. Be loud. You are self-promoters. Housing is a problem. We're working on housing. BC Housing, if you're here, I really need a different answer than you gave me. Daycare is a problem. Yeah, seriously, we've got a seniors housing complex with 22 rooms in it. I need a waiver for 6 months. I can house a doctor. Just give me a waiver. Burnout is a massive problem among healthcare workers. We all know this. My sister's a nurse. We know this. I often cite toxic workplace environments. I'm not talking about my town right now. Nobody likes me talking about that. What I have to say on that is people that reach out tell me they've lived through those experiences. It's whack-a-mole. You need to be involved. You need to take action. When it pops up, you need to whack it down, keep on top of it. You got to be vigilant on that. What we are learning as a community from this, that we can do things from the bottom up, that the health authorities and the ministry really can't do from the top down, which is basically how it's working right now. I'm a communicator. Communicate. Never stop reaching out and talking to people. Know the players in your system, the clinic, who runs it, the doctors, the health authority managers. Shout out to Carl Meadows from Interior Health, who has come and helped us go to a coffee table level to discuss all the issues in our hospital and has solved so many problems in a short time. Hold on to the good ones. BCEHS unit chiefs, anyone who will talk to you, talk to them. Your job is to find out what you can do for your community to help. Sourcing housing, finding daycare, connecting new hires to potential friends, to communities, to interest groups. Loneliness among overworked healthcare workers that are moving to your town is a theme I hear about continuously. You need to take care of these people like they are family. Don't be overly critical. It's really hard in this to be overly critical, but creating, as rightfully Minister Dick said, nobody wants to hop into a crisis. They want to hop in and be part of a solution. So you need to balance that very carefully. But you will have to occasionally speak out when things go completely sideways. And you need to give a heads up to the people that you're working with in the system that you're going to do that, and it's what your citizens expect of you. It is definitely not your job or your district's job to financially support the healthcare system. We get asked of that all the time. What we can do is get involved. You have to. I'm perfectly fine funding recruitment with other groups. You need to get into the recruitment business because it is an area that is lacking. You need to send people to the professional shows to talk about your community and sell it up. Fund local recruitment, even if you pay somebody else to do it. Build trust and maintain that trust with stakeholders. Don't burn anybody. Build local capacity. If you have community forests, if you have opportunities with scholarships, target them at healthcare and target them at local kids. In the last 3 weeks, because of the amount of discussion about what the actual problems are, 11 community members have stepped forward and signed up to take BC ambulance training. And finally, keep steady pressure on. You cannot let off. Thank you.
It hits me when I see community members having to step up like this. And I think you can hear the passion already in the voices that are coming to this podium. Thank you, Mayor Blackwell. From an urban perspective on this issue, please welcome Councillor Pete Fry from the City of Vancouver.
Thank you, and thanks to my colleagues for reflecting some of the crisis we're all experiencing, and judging by the amount of us here in the room, this is something that all British Columbians and local governments especially are feeling, and feeling in a very profound way. So I'm a Vancouver City Councillor from the unceded territories of the Musqueam, Squamish, and Tsleil-Waututh peoples. And we also have a number of the province's biggest hospitals, childcare hospital, cancer treatment, HIV/AIDS, leading heart department at St. Paul's Hospital. So our hospitals and some of the impacts that we're feeling on our healthcare system in the City of Vancouver impact all British Columbians, because inevitably many of us from around the province will have friends or loved ones who have to attend hospital in Vancouver. We know, for instance, in our local health authority, Vancouver Coastal Health, that at our hospitals and community care facilities and long-term health facilities, the new normal is staffing shortages. We had over a single 4-week period this summer in Vancouver Coastal Health, the health authority logged nearly 3,000 individual instances of units working without enough nurses to meet patients' basic care needs. So that's almost 3,000 patients in total who were stranded without that. Our emergency departments are especially strained. They're working short nearly every day. And that's not just in the emergency departments, that's also trickling into the medicine wards, the neuroscience, long-term care wards. The shortage is starting to infiltrate and affect all areas of care in the City of Vancouver. We have a serious nursing shortage. We know this through COVID. We've seen a debilitating impact on the nursing population. We're having a real challenge with recruitment and retention. Obviously, Vancouver's housing prices are well renowned, but we know throughout British Columbia that housing is impacting the ability to recruit and retain the healthcare workers that we need in our community. So things like affordable housing, but not just housing, even things like parking and childcare and those added things that can support the healthcare workers that we need. As we know, of course, 1 in 5 British Columbians right now don't have a family doctor. In Vancouver, we also have been really feeling the impacts of the opioid, poison drug supply overdose crisis. We have the highest rate of death from opioid overdoses has been recorded in Vancouver, but obviously Thompson, Caribou, Northern Interior, throughout the region, the entire province, we're all seeing the impacts of the overdose crisis. These impacts are manifesting in ways. We had an emergency closure. Now, this was technically in electoral district A, but it's Vancouver's UBC hospital, and it had to close for a lack of staffing, and that directly impacted St. Paul's and Vancouver General Hospital because we saw overflow patients heading there. We know there's not enough nurses. We know that there's also a need for security. A lot of healthcare workers are actually on the front lines of a lot of serious issues. And in the last 5 years, we've had 2,200 healthcare workers in the acute care department have had time loss injuries due to acts of violence in their workplace, which kind of brings me to something. Yesterday, we had a conversation around police reform here. And what was absent in that conversation was really, it was great to have the Ministry of Public Safety there, but we didn't have the Ministry of Health there. And what we're seeing, certainly in Vancouver, but not just Vancouver, I know in Prince George, Nanaimo, smaller urban areas throughout our region, mental health is a serious impact on our healthcare system, and we're seeing it. We just had another random stabbing in Vancouver, a very serious stabbing. The young man is expected to survive, but he was just randomly attacked on the street. And I don't want to presuppose that this was an incident of mental health, and certainly wouldn't want to stigmatize mental health issues, but we know from the Vancouver Police Department that 73% of all these random attacks that are happening are related to mental health issues. And so that is another part of this healthcare conversation that we need to include with the Mental Health and Addictions and with the Ministry of Mental Health and Addictions, who's of course empowered through the Ministry of Health. And I think that's why Minister Dix's comments around the sort of healthcare teams and the community healthcare model is so important. When we talk about the social determinants of health, and there's this Venn diagram with healthcare right in the center. And so what are all the intersections? Housing, poverty reduction, social services, access to transit, counseling, childcare, education and early childhood intervention, food security. These are all pieces that kind of impact our social determinants of health. The approach we need with looking at, not just in the city of Vancouver, but for all of us, is how that community care model can wrap around these various pieces and knit together all these complex gaps and really come with a holistic health approach for community care for all British Columbians. So with that, thank you.
Thank you very much for sharing your challenges that your communities are facing and for setting the stage for the next set of conversations that we're going to have.
When Today in BC continues, we'll listen to the panel's suggestions for transforming the healthcare system in British Columbia.
Why spend hours searching dealerships, comparing makes and models? Find the best of BC's inventory in one place, todaysdrive.com. You'll have access to inventory across BC, where you can easily find a vehicle that fits your needs and gets you where you need to go in comfort. Get in the driver's seat. Don't miss out on the many options we have available for you. Powered by Black Press Media, todaysdrive.com connects you with exclusive new and used car deals.
I'm Peter McCully. Today in BC is a Black Press Media podcast. Once again, here is President of the UBCM, Lori-Ann Rutenberg, as she introduces the panel to discuss transformative changes to the healthcare system in British Columbia.
Now, to focus on potential solutions to the crisis, we have 4 experts for you here. Troy Clifford, Provincial President, Ambulance, Paramedics and Dispatchers of BC. George Abbott, President of Circle Square Solutions, Inc. and former Minister of Health. Dr. Carrie Jang, Faculty of Medicine, University of British Columbia. And Dr. Ray Markham, Rural Family Physician. While this panel may offer many thoughts and possible ways forward, please know that there were many additional experts that were unable to attend today, including those who represent our other healthcare professions and health regions in BC. I'm going to invite the panelists to provide a bit more background on themselves and how they're connected to healthcare. Troy Clifford, you can start, please.
Thank you. I think I know a lot of people in the room, but I have not met you all. And I just want to, first of all, thank Minister Dix and you all for the opportunity to be amongst you. I'm honored to have the opportunity to have this conversation. And I also want to just acknowledge on Sunday morning, our colleagues in Alberta lost a paramedic in the line of duty in a car accident. Dallas Boyko was hit by a person driving the ambulance just outside of Edmonton. It really brings home how dangerous the work we all do and the risks that happen every day. And none of us do any job and expect not to come home at night. So I just wanted to acknowledge that. I'm a 34-year paramedic in BC. I've spent my adult life as a paramedic and advocate for this profession and our patients. And that's my relationship to the municipalities. I've grown up in a small town, and I work across the province on behalf of our 4,500 paramedics and dispatchers that provide care in 198 First Nation communities and 38 chartered Métis communities across BC. And my role is to lead an organization that holds a dual role of healthcare, frontline healthcare, and public safety, which is a unique role in all areas. People want to pigeonhole us into one or the other. We're proud to be part of both. So I'm excited to have this conversation.
Thank you very much. Next up, George Abbott.
Thank you. It's a great honor to be asked to speak to you today. It's a great honor for us recovering politicians when people acknowledge we're alive, never mind still have something to contribute. So thank you. Thank you for that. My background, I spent 17 years in local government, most of that as chair and director at Columbia-Shuswap Regional District and post incorporation at the District of Sicamous. Fell in with a bad crowd in 1996, ended up in the BC legislature, was there for 17 years, and among the highlights of that period for me was being your Minister of Local Government from 2001 to 2004. It provides me annually with the one guaranteed free lunch I have at the Honorary Life Members Luncheon. So I appreciate that. Also had the opportunity to be honored to be a Minister of Health from 2005 to 2009. Since leaving the legislature, I tried to make some sense of the previous 35 years. I've done a doctorate in political science at the University of Victoria, done reports for government on a variety of things, forest contractor sustainability, the South Island Governance Review, and with Chief Maureen Chapman, the 2018 Fire and Flood Review. All I hope are useful contributions. Currently chair of the board at Technical Safety BC and chair of the board at the Institute for Health Sustainability and Transformation. So thank you.
Thank you for that, Mr. Abbott. Up next, we have Dr. Carrie Jang.
I'm delighted to be back at UBCM and so many familiar faces. I retired from Vancouver City Hall in 2018 after 10 years as a city councillor, and since that time I've lost 16 pounds. My hypertension is back to normal. I'm no longer diabetic. And so I feel that if we were all to quit politics today, we would reduce the incidence of those diseases in the province by tenfold. So if you haven't handed your papers in, think about twice. Seriously, I've been at UBC for, they tell me now, they sent me an award for over 25 years in the Faculty of Medicine. I'm a professor of psychiatry, and I've been teaching medical students for many years and doing biomedical research. I've also recently, for the last 4 years, been appointed to the Provincial Health Services Authority, and so that oversees things like Children's Hospital, the BC Cancer Agency, Renewal, all the provincial programs that we look after, and as well as the newly formed BC Ambulance Emergency Health Services Board, the Ambulance Board. And I work very closely with Troy now, so we often duke it out a little bit here and there, but we're starting to make some good changes. I'm sure Troy and I will talk a bit more about that. But delightful to see you all, and looking forward to this panel. Thank you.
Thank you, Carrie. Up next is Dr. Ray Markham.
I'm a rural GP in the village of Valmont, which is traditional territory of the Carrier Kletlechene people and the Simpa Shugwepma people. I've been there over 20 years, and just to tell a little bit of the story in the face of challenges, as I think we've heard, are not new, and there's great opportunity and challenges. When I came to Valmont, it was actually through initiatives that the provincial government had set up, that the community had set up, that the local health authority had set up, and we've shifted from a system where half of the people in Valmont were going to Jasper for healthcare. They're now all coming to our local community. We have people from Jasper actually coming to Valmont. And we worked in partnership over a number of years to try and build up the system, and probably after about 10 years, became quite apparent that there were some things you could do locally and some things actually that were stopping you from doing what you needed to do at a different level. The end game here for me always is, as my colleague and partner in Vermont would say, walk the road with people. so to help people, but there are things that are not at the clinical interface that affect that. So that got my involvement in things provincially. And so I'm a clinical professor at UBC, involved in teaching and training. I've been involved in kind of continuing medical education training for rural family physicians, particularly for quite a while. And then about 6 or 7 years ago, took on a role with the group, I lead a group called the Rural Coordination Centre of BC, which is really about improving the health of rural patients and communities. It brings a rural perspective, a rural physician perspective to improving the health of rural patients and communities. UBC Health is all the health disciplines, all the medicine and nursing and occupational therapy and all of the other health disciplines is supported through UBC Health, and I'm Health Systems Advisor and chair the Health Systems Partnership Table for that group. The touchstone for me always in all of these things is this going to make a difference to my clinical relationship to my patient, to the encounter on the ground. And if it's not going to do that, then it's probably not worth pursuing. And I think there's huge opportunity. I just do want to say it's been super amazing to see all the flags here. And I'm going to give you a gift. One of the sayings we have in the Rural Coordination Centre is, when you've seen one rural community, you've seen one rural community. And my gift to the province is, when you've seen one community, you've seen one community. And so the idea of actually communities driving things is super important. And the idea of partnership. So I love your logo, your little catchphrase. I think that really sums up, if we look at anything here, the value of one. Everybody kind of matters and everybody has a stake in our province, and the power of many. No one group, including the Ministry of Health or any other group, has all the solutions. And so really excited to frame kind of solutions in that context. Thank you.
Thank you, everyone. I will start by asking the panelists the first of 3 questions, and they'll each have an opportunity to respond with 2 to 3 minute responses. So for the first question, from your perspective, what do you see as challenges in the healthcare system at this time?
We've talked about a lot of the problems here, and I think it's going to be a consistent theme, but you all know the challenges in your community, but I'll talk to it primarily from an emergency services ambulance perspective. And recruitment and retention is absolutely, they go hand in hand. And we have to recruit from communities, your communities, Indigenous communities, right from high to Guai. But we can't forget, we need to recruit in the metro communities. We can't be forcing people to move to communities that they're not committed to or devoted. So unless we recruit from those communities, and to recruit, we have to have work and meaningful work to offer them, and wages and benefits. And that goes against our precarious on-call model. And we talked about what the minister talked about, moving to a more full-time and sustainable, meaningful work. We need to compensate people for the work they're doing in rural and remote communities and urban communities. So that's our biggest recruitment challenge right now, is compensating people but recruiting from communities. Retention is the same thing. We need to utilize and train our current paramedics up to higher levels, from EMR to PCP, PCP to ACP, and that needs to be across the province. We need to bridge that gap between the disparity between paramedics and our partners in police, fire, and public safety and health. We're about 30% behind. That's a big challenge, and when you're in a human resources capacity or challenge in every industry, every profession, that's a reality. We're competing against industry where communities like Rays, where Valemont, where people have a choice to go work other places in industry, and they make considerable amount of money. So that's the reality we're facing in this province, not just in our profession, but in industry, in trades, in all the professions we're talking about. So we have to address that disparity. We need to recognize the dual role of public safety and health that has digressed in our ambulance service since our move solely into health. That needs to be recognized. That's how we work with you in municipalities on emergency management. We have a lot of emergency and natural disasters in this province. Every one of us has experienced it. And unless we're integrated in the community health and the community municipal emergency management, the system doesn't work. And workforce housing was mentioned. So these are some of the challenges. But at the end of the day, recruitment and retention and support locally for recruitment, training, and integration within municipalities. And working together to lobby for what the needs of those communities are, not telling you what you need.
Thank you.
Try to, in a couple of minutes, lay out what I think the current challenges are. The solutions I'll leave to another time, because it's tough to get it all into 2 minutes anyways. I think context is always really important in understanding any challenge. Minister Dix talked about COVID-19 and the impact it's had on the healthcare system. I completely agree. In 2009, we had a brush with a pandemic called H1N1, but it was a very modest impact compared to the novel pandemic COVID-19. It has been devastating for a whole lot of people in a whole lot of ways, and one of those ways was stress and fatigue. Over now 2+ years, it's been an enormously difficult time for physicians, for nurses, nurse practitioners, ambulance professionals, right across the board. This has been a very tough time, and we're now seeing some early retirements, in some changes of careers, the impact of all that stress and fatigue across a long period of time. Not surprisingly, I think much of the focus in the media and in the public in recent months, as we have slowly perhaps been emerging from the pandemic, is access to primary care, access to a physician. That's an issue for lots of people across this province, and including my kids. It's an issue not just in British Columbia, but across Canada. It's not something that we can wave something attractive at Ontario and think that they're all going to come here. It's not going to happen. So there's that. The second piece I'd say, and again, forgive me, but I think it's important to say, the shortage of primary care physicians means that a lot of pressure is brought to bear on emergency departments as the default home for a lot of things which might otherwise be managed within a primary care system. And I think we may even see it become more intensified in the months ahead. This is a very timely conversation. This is a very challenging conversation. There are not a lot of easy answers, but it's good that we're asking these questions and hopefully moving the ball forward. Thank you.
Thank you. Carrie.
Thank you very much. This first question is really about challenges, so I'm going to focus a few that we see from the universities and training perspectives. So biomedical research throughout the province has shown that demand has tripled, if not even greater. Things like cancer care, cardiac care, and the opioid crisis are probably the number one reasons for death in our province and number of excess deaths. So those are the diseases that we're talking about now. With this increase of demand, the scope of practice has also changed for new physicians. When I look at our curriculum at UBC, what do we teach now? Before, in the old days, it was a lecture-based approach. You sat there, they listened, and they went off and did their labs, and then eventually they wrote the Royal College exams. Now it's very different. We have case-based learning. Before, that was problem-based learning, in which now you have clinical preceptors actually sitting and chatting with the students about cases that they learn from. We also teach our students to work in teams, because one of the big issues they have is that they don't want to have to make decisions sometimes on their own. It's better to have a colleague in which to bounce ideas off or to double-check things. So that's part of the training, which in some areas where there's only one physician or no physician, there are no team. They also are discussing now a lot about overhead issues. In the traditional model, you open up a private practice, you build, you're paid for your nurse or whomever, your receptionist, all yourself. They don't want to do that anymore. Our new med students, new doctors, they says, no, we don't want to do this. We want to see something like the national health model in the UK, in which the clinics are set up and they actually go to these small towns somewhere in the UK because the government pays for the clinic and all the support staff and whatnot. And so this is all in transition now. And so this is what we're feeling on the streets today. Issues about recruiting to the interior. UBC has been struggling with this one for over 25 years. When I joined UBC, we had the medical students, so how do we get more physicians in the north, on the island and all this? And so they dangled money, right? They said, hey, it's a lifestyle change. It'll be great. You can be a Grizzly Adams, go working up in the north. It didn't work so well. So when we expanded the med school over 20 years ago, the first thing we did was, let's recruit from those areas, hoping they would go back home once they finished. So we had the expansion of the University of Northern BC, the Island Medical Program, now University of Okanagan, and now they're talking about rival SFU in Surrey. But that's the issue. But the problem with all this, of course, is that even if you were to open a new med school or to expand UBC once again, we're full. Every single student that we see, that we train, they need a clinical preceptor. And so if they're busy seeing patients, they're not going to have enough time to also go out and supervise students and make sure they don't screw up. And I know that's been a real issue as well. And it's not only that, it's support staff, whether it's a back end for the office and whatnot. And this is all very key. So these are challenges in the transition of change. So it's the change in how we practice, how we train our physicians, as well as demands. People still are demanding to see their physician on one-to-one basis like they used to. But the change of practice has changed a bit, and I think this is now we're starting to see a bit of the slippage because of this. Thank you.
Thank you. Dr. Markham.
Silos is our first challenge that I would say, and we've been working in rural on a model called the Partnership Pentagram Plus, which includes policymakers, health administrators, the people, so citizens, linked sectors, which is industry and nonprofits, academia, educators, and providers. And so I think that is something that actually we do need to look at breakdown as silos within the system. Risk aversion is another big challenge I think that we have, and the way we're managing risk at the moment is we're managing risk to institutions and to providers. We're not managing risk to patients. I can give you a perfectly safe hospital where nobody is ever harmed. Just shut the doors. At the moment, those doors are being shut. What do we value? We have historical systems that value things that no longer actually are the value that we need. The fee-for-service system, as you heard, values volume. We need to figure out other things that we value and how we support and resource those things. And then I think we need to expand our definition of who teams are, and from a narrow definition of regulated health professionals physically in place. First Nations, Health Authority and First Nations community have been doing a lot of work at laddering, bringing people into the system and kind of from community and then slowly bringing them in. So that's the other challenge, is actually just changing our mindset of what a healthcare team is. And I'll stop there.
Thank you. So the next question I have for our panel here, what are the short-term solutions for the issues you have raised? Dr. Markham, would you like to start?
Firstly, I'll say I think working in partnership is super important because everybody brings things together. So I would say actually valuing the opportunity, and particularly for a municipal government, I think that is a role. If we talk about the uniqueness of each community and how we can have a bottom-up solution, working in partnership and the local government actually being able to hold that space for these local partnership tables that can actually drive what is important and what's going to work for our community. We talk about the team, and I would say there's been a bunch of work already done in rural. Rural is the canary in the coal mine, if you like, for the health system. We've been seeing challenges like this for quite some time, but it's not separate from the health system. The rural framework that Minister Dixon, the Premier, announced a couple of years ago came out of a Partnership Pentagram Plus process that we supported. And one of the two things that highlighted were transport and virtual care. And those things we've seen significant movement. So virtually enabling and virtually supporting teams, including training in sites, I think is another opportunity that we have. Obviously, recruitment's going to be a thing, and pulling people in from other jurisdictions where they actually have skills that may be able to help. I'm going to say recruiting responsibly. I have an interest in global health. I take teams to work in Zimbabwe. If we're recruiting from low-resource environments, we need to be putting back into those low-resource environments in some way. But very pragmatically, we could have associate physicians in communities doing a return of service before they get into postgraduate training programs, building roots in communities, and then actually getting into postgraduate training programs without any return of service would be something that would be a short-term solution. Troy and I have chatted before about this idea of the silo of an emergency room, especially in a small community, and paramedics, and kind of each of them not having enough. Put them together. Have the health authorities and the ambulance services working together around services.
Thank you for that. Dr. Jang.
Thank you very much. Short-term solutions. Well, in medical school, there really are no short-term solutions because we have to maintain the standards of our training. We have the fantastic doctors that we have. None of our students have ever failed the Royal College exams or the U.S. boards or whatever. We want to keep it that way. We're very proud of the fact that we produce some of the finest doctors and nurses and other practitioners in the country, if not the world. So with that said, it's a little difficult to really talk about short-term things we can do. One of the things we do, and we have done over the last few years, is really push family practice as a real viable career option. Many people believe that becoming a specialist, like a surgeon or an oncologist or something, is the way to go because it has all the glamour and whatnot with it. But we're saying family practice is a great career. And so now we actually call it now the Family Practice Program at UBC to emphasize that fact. We also try to encourage to go up north and other places and join other teams that might be there. Become hospitalists if you must in some of the regional hospitals. Our goal is to keep them off West Broadway. That's where they all want to go. In general, we've been talking a lot about scope of practice changes, and COVID really accelerated that. So, for example, instead of doctors giving you your injection, as we saw with COVID, it's now pharmacists and everyone else who can do that. Making better use of our resources. As one person put it to me, a physician is like the urban outfitter. They get you ready to climb Mount Everest, but we need all the other health professionals to get you to the top of Everest, which is health care. And so we've been working very hard to build our relationship with nurses and all the other groups. As I mentioned, I'm on the board of PSHA, so we now have a VP nursing that works very closely with our hospitals and whatnot, and our physician groups to make sure everything is much more integrated and they can pass off to one another. The minister talked about some pay changes. He's in discussions now with doctors at BC about different pay, giving some relief to overhead expenses. There's been discussions about specialists. We don't pay competitively. Let's put it this way. George here said we just can't waive something to get the ones from Ontario, but if you waive enough dollar bills, they will come. We know for a fact that we're not competitive and that we had made a number of offers to oncologists, and every single one turned us down simply because we weren't competitive and they went to Alberta. And so the minister's aware and has been looking into those types of issues with us. UBC has been pioneering, for example, with the use of clinics. So they're setting up clinics in which they're all paid a base salary of some sort. As long as you keep going and don't go somewhere else, they continue to get paid, as opposed to a fee-for-service model. And I'm in one myself with my physician. It's a training one as well. And it seems to be working well. But that's a model that we're hoping to integrate more. And so this is where we are when it comes to short-term things. The other things that we often do is that we have so many people applying to UBC Medical School. We have, 240 we can accept a year thereabouts. We have over 2,000 applications every year. And the average time it takes our student to get into UBC is often 3 or 4 tries. And these are brilliant students, absolutely brilliant students, and so they land up going elsewhere. And so we're not only not able to train them all, we're losing the best and brightest British Columbians sometimes, which I find really a travesty. Thank you.
Thank you, Carrie. Mr. Abbott, what is your short-term solution?
Great, thank you. So I want to make this observation, first of all, that quick fixes are really tough to come by in a system that is typically very resistant to change. And often just enunciation of the words scope of practice will excite a lot of debate about who should be doing what within the system. Nurse practitioners were quite new at the time I was minister. They have proven to be a great asset to the system. We need more, and we need to think about a kind of rationalization of their scope of practice versus full physicians. I suspect the Ministry of Health is already working on some of the short-term solutions I have in mind, but who can help? Recruitment is important. I suspect Carrie's right that waiving more dollars will be a part of that. But Adrian, Minister Dix, has to have that difficult discussion with Treasury Board. I can tell you my interaction with Treasury Board generally ended up with me being beaten and placed in a corner when asking for more funds. I suspect he'll be much more successful than me. I think one of the areas that they could look at is recently retired physicians, nurse practitioners, nurses, and so on. Building an attractive package to bring them back for 1 or 2 or 3 years, I think might be extraordinarily helpful in getting us through a very difficult period, whether it's as locums or other positions. I think we are generally in this hugely difficult period. International medical graduates are also a potential source of help during this period. One of the things we tried to fix 05 to 09 was figuring out better ways to manage international medical graduates. Never made the kind of success there that I'd hoped for, but I think they still potentially represent a resource that we can build on. Are there incentive packages for limited licensure provisions for IMGs that might get us through these 1 to 3 critical years? I'd like to think so. I think we need to look at what other provinces are doing and bluntly steal, actually, some of the interesting things that are being done in Ontario and elsewhere. It's one of the times when I think theft is an enormously benign thing, is the realm of ideas. Other ideas are around longer-term solutions I look forward to discussing in a moment. Thanks.
Great, thank you. Troy, what's your short-term solution?
Thank you. Solutions, that's where I like to go. We've been talking about the challenges and the frustrations and the heartbreak a lot, but they really get us to the solutions, and we have to have the solutions, and that's what this conversation's about. So I think for the emergency service, it's really acknowledging one thing that's really come up in the last couple of years is the role of what is essential in our lives. And it's not just seen as the police, fire, and to an extent ambulance, but I think it's really exposed what we consider essential, basic utilities, food. That really emphasized that, and it really changed, I think, our perspective. The issues we're seeing did not happen because of COVID or because of the opioid crisis. They were exposed and definitely amplified in the last couple of years, but this progression started a long time ago. And it's not just about not having an ambulance in your community, the physicians, all the things my colleagues have been talking about. And so that where the short-term solutions are, first of all, acknowledgement and recognition that paramedics are part of the community health team, the primary team. we talked a lot about here, but we always come in as an afterthought. And that sounds great, Troy, you're talking because that's who you're advocating for. But I see these short-term solutions as community paramedics. Many of you have community paramedics in program. That program has lapsed. It truly is a solution. It's community paramedics were integrated into a model that didn't work, that we tried, and it was unsuccessful. The scheduled on-call model, and that's in rural and remote. But we need to get the standalone CP program, and it needs to be supported as part of those community and primary care teams, because they are the solution, and they will help. They do the check, and a lot of communities that you are in, the ambulance service is the only health care in town. And unless we include them and train them and utilize those staff from those communities, we're not going to succeed. So that's part of the solution, is recognition and acknowledgement of how they fit into the team. Utilizing our resources, training from your communities, short term, some of the stuff we've already started, but really recruiting. And the biggest thing is competent these people in their community so that they stay and they will step up, because people will step up. And they are. So part of that team community focus are increasing, the minister said, to full-time positions in a lot of communities. There's going to be communities where we're still going to have some sort of on-call model, but we need to compensate them properly. A short-term solution immediately is when your community is short-staffed, upstaffing those call-out positions, those kilos, if you wish. And I know I'm talking our jingle, but a lot of you have heard that term, the call-out, the $2 an hour stuff. Let's upstaff those communities. If you're in Clearwater and your ambulance has gone to Kamloops because the hospital closed or out of community for a period of time, that secondary ambulance needs to be paid and put on coverage so that people in your community are left without an ambulance. Insert town here. And I'll go to another short term. We know that the best place for addictions and mental health is not necessarily in an emergency department or in the back of an ambulance, unless they're having a crisis that needs immediate care. We don't have referrals, and in most of your communities, it defaulted to the police and the ambulance to respond to these calls. And we all agree that may not be the best for those care. So we need referral patterns. Same within Metro. We need people, alternate pathways. We need the community support, these teams we're talking about, and that's right from remote to Metro. So those are the short-term solutions, and the longer-term solutions are that. But right now, we need to immediately ensure everybody in your community has access to an ambulance in their time of emergency, regardless of where they are in this province. And that right now is not happening.
Thank you. I know that each of these questions could probably take 5 to 10 minutes just to discuss, and the next one probably could take even longer, because I'm going to ask you what are the long-term solutions to the issues you brought forward. But just reminding you, you only have 2 to 3 minutes to speak. Carrie, would you like to go first?
Thank you very much. Happy to do that. The long-term solutions, though, this is the fun part where we all think about the 10 years from now and what we're going to do. And so certainly from a training perspective from the universities, we talked a little bit about foreign credentialing, looking at international medical graduates. But I've got to warn everybody, this sounds good on paper, but a lot of medical schools are quite different across the world. And some are quite frankly not as good as ours. And we may have to put them in a lot of training. So this is really something we have to work out with the regulatory bodies. We may want to look at things like accrediting other universities from other places with Canadian standards, like all health authorities, all hospitals, we all go through accreditation. Why not do one at a training place in Australia or in England or somewhere like that, or Shanghai, where they have really good health care, so they can immediately transfer things. And that's also a university thing, right? Where we look at different programs, see which one's going to work best and which one's equivalent to ours, and vice versa, because they do some things better than we do too. Work both ways. Screening. Things like screening, this is an interesting one, because best practices say we ought to always be doing preventative care. So like mammographies and colorectal cancers and whatnot. And those are quite cheap and easy to do compared to surgeries and long-term cancer care and whatnot. And we're trying to push more and more of that, but the uptake has been actually fairly low. Some of the things we want to do with, say, with ambulance services and whatnot. Like one of the big issues is, of course, where do you build helipads? Where do you put landing strips? If they're far away or they're an airport is away from a hospital, that's a drive. I remember coming in one day and they had Canada Cups. I came from Alaska, had a brain aneurysm, had a bleed in my head. The first thing the guy asked me was, anything to declare? But being able to put ambulances closer to hospitals, for example, is really going to be keys, because the paramedics, with their advanced training and skills, they can also work as supernumeraries in the hospital when the time comes. They're not somewhere else. They're actually with healthcare professionals that can build that team, build that rapport, and build a better way of working together. So things as simple as building a station close to a hospital, building helipads, landing pads that are close to where people need to go would go a long way.
Dr. Ray Markham, what's your long-term solution?
So I think there's a lot of opportunity in removing administrative barriers. So I see that at two levels. I think I heard the term gatekeeping here, and we talked about the challenges for people even coming from other provinces. I can tell you there are challenges for moving between health authorities within our province that probably don't need to be there. I work 200 kilometres north of Clearwater. We have actually gone out in years past and helped out in Clearwater, but it is a raft of paperwork to do the same job in Valmont and Clearwater, and those things need to be looked at and changed. The other thing that I would say would be really training in areas that you want service done. So if you're looking at primary care, then a bulk of training needs to happen in primary care. If you're looking at communities that are in higher need, then training needs to happen in those communities. And there are a lot of ways to do that. Digital enables. The digital divide is one of the things in rural and remote, and certainly in First Nations communities, that's something that needs to be addressed, to be able to support that, to bring kind of those supports that need to be brought in virtually in order to enable that kind of training in those setups. I did mention the ethical recruitment through international. There are programs to upskill and ensure quality, but I do think we have an obligation. I do work in Zimbabwe, and I'll tell you, I work in a community that has 70,000 people. Their physician supply is one doctor, 2 mornings a week. So when you bring a doctor from those environments, and I talk to somebody with that accent, we're bringing them from a place that really has need to a place that has need, and people will move. But we need to be really looking at how do we ethically give back to those environments and those contexts. And then the last piece I'll say, and it's a project that we've been working on in our local community, but I think is a game changer, is health data needs to be owned by the people. That patients need to own their health data. And the provincial health data system needs to be aligned to make sure that everything connects to the patient, not to the health authorities, not to the hospital, not to the general practice office, but to the patient. And I think that would be transformative in the system.
Thank you for that. I'm going to go to George next.
Thank you. I don't believe there's any one long-term solution that we engage in it and it fixes the system. There's got to be a number of solutions, not a single one. First and foremost for me, in terms of the future of the healthcare system and long-term solutions there, is expansion of team-based primary care. Minister Dix talked about that earlier, and other members of the panel have talked about that earlier. I was convinced after 4 years as a Minister of Health, that's where our greatest hopes lay in team-based primary care. We've got some early and excellent examples of team-based primary care in British Columbia. We can also look, as Carrie's noted, at Great Britain, at New Zealand, and other jurisdictions that have taken the model. And I do hope that one of the products that comes out of the undoubtedly difficult discussions that will occur between the doctors of BC and the Ministry of Health and the government of BC will be an openness to a range of models that might fit the very different circumstances that we have on the downtown east side versus Sicamous, my hometown, or Pouce Capet in the north. There's all kinds of different situations, and we need different models to provide for that. But I think overall, it makes huge sense to go to team-based primary care, seeing perhaps physician-led, but teams including nurse practitioners, nurses, pharmacists, physios, dietitians, and so on. Team-based care responds much better to the principal driver of demand in healthcare, and that is chronic disease or chronic conditions. There are a number of these that affect many British Columbians: diabetes, hypertension, arthritis, mood disorders on the mental health side, all of the demand skill sets that doctors don't necessarily possess, that a pharmacist, for example, may possess in greater quantity. So it's utilization of a range of skills, and team-based care, I think, allows physicians to do what they do best, which is to sit down with the patients, to diagnose what the patient need is, what the range of services they may require, and then support a team that can then step in and allow them to continue to do their work. So team-based primary care, to me, is number one. And I suspect it's over to you, Troy.
Yes, you're correct.
I can't disagree with that in any shape. That is the future for care in communities, regardless of how big it is. But I think long-term solutions obviously are different. So I'll focus on that. And I think absolutely having a community care model, and it's flexible for the different communities we have. But There's a few things that need to, I think, primarily from an ambulance perspective and how we are part of the communities. And I mentioned earlier, sustainability of an expanded CP program, community paramedic program, in rural and remote and Indigenous communities, but also expanding it to the metro and urban models that can work with those communities, the addictions and mental health, and working with our partners in these community response teams that are being piloted in North Van and New Westminster and Victoria. Working in our harm reduction centers, there's where paramedics who are integrated in those communities can really help out. But we need to move away from an old mindset that Haida Gwaii does not deserve a full-time ambulance. Who says that? And I think you heard the minister talking about that. That's been a trajectory they've been going on. We went from 30%, I think we're up around 54% of our services full-time. A lot of that is in rural and remote, and we're obviously advocating for that. And we need to, but that also can expand the community care to help communities like Valemont, where they have one physician and maybe one nurse. They need our help in the clinic when they have a cardiac arrest or a serious patient, and that works very well. And that's where that team concept comes in. So that's one thing. We need to expand training in communities. We need to take the training to Clearwater. We need to take it to the Haida Gwaii. We need to take it to the Peace region, the Kootenay, so that people can be trained and recruited in their communities. But we also need to pay them. We need to compensate them. We need to be culturally sensitive to our different communities, our Indigenous communities, our seniors, our marginalized people in the downtown east side. Everybody has a story. And I think that's really what makes me proud of the paramedics and dispatchers in this province and the people we work with in health and public safety. It needs to be supported, but we need to have advancement of training both externally, but we need to utilize our current 4,500 members to expand their training and give them opportunities so we retain them. But 30% of our members, paramedics and dispatchers in your communities, are injured psychologically. We're the highest of any profession. And until we get their bodies and their minds healthy, we can't help our patients to the maximum. And that's what we're working on. We have a lot of supports in place, but that's a long-term solution that really needs to change. In metro and urban, we have large communities and population bases, particularly you take a Fraser Valley or the large growing communities across the province, the Okanagan, Central Island, the Fraser Valley, Maple Ridge and Pitt Meadows, that don't have ambulances for large portions of population base. And that's growth that's been happening for many years. We need to get to that 8.59 minutes average on highest acuity calls in the metro and urban areas in the 90 percentile. We're not meeting that objectives in many communities across the Lower Mainland in urban centers. And we got to get there because people need to know that an ambulance is there in their time of need. If the ambulance service is not working to a maximum, it's the entry point to the emergency healthcare system. And if it's not working, the system doesn't work. And I think that's really some of the long-term solutions, and I think they're on the path. We just got to get through with those short-term solutions so that we can get time to implement these things, and we will get there. Thank you.
We hope you found this podcast informative. Reimagining Healthcare in British Columbia was the theme of one of the sessions held at the recent Union of British Columbia Municipalities meeting. If you have suggestions or comments, send us a voice message to podcast@blackpress.ca. You may be part of our podcast mailbag segment. You'll find Today and BC Podcasts on iTunes, Spotify, Amazon, iHeart, and Google Podcasts.